All right, we'll get started. Thank you, Mountain Brook Fire Department, for hosting us today. Really appreciate it. We're downtown at Mountain Brook. We're going to have lectures until about 11. Then we'll do lunch, and we have skill labs with the doc. So for those of you that are online watching, if you want to come do some hands-on training, we're going to do some mega codes, some pit crew CPR, surgical airways, and advanced airway management. We'll also do some ultrasound training with one of the new ultrasounds that has artificial intelligence that actually labels body parts. So it's like cheating. So we appreciate everything. We'll get started. Can't lose the internet. That's how we survive. Making no political. We're good to go. All right. So in case that didn't come through, we're at Mountain Brook today. We appreciate it. We're going to do labs this afternoon about noon after lunch, but surgical airways, advanced airway management. We'll do some mega codes, pit crew CPR, and then play with some ultrasounds as well. I got the 2 fellows here and also a senior resident. So you got 4 docs come down, ask us questions, harass us, challenge us. All right. Thank you for almost smiling. Good. All right. So EMS challenge, for those of you online that have not seen this before, we've been around since 2014, and the goal is to increase the physician-led Con Ed, trying to rebuild some of the relationships between the ERs and EMS to improve patient care overall. For your certificate today, if you're in-house, all you got to do is scan the QR code, and that will get you to a link to fill it out. If you're online, you can use the chat feature and scan that link, or go to that link. Or you can always email alabamaemschallenge@gmail.com, and that'll get your Con Ed as well. But if you're going to use the email method, please get that email to us today by dark so we can get that stuff out to you. Educational opportunities, we're going to be at Gardendale Civic Center on October 12th. We'll be at the Oxford Civic Center on the 28th. In November is the Alabama State EMS Conference. SMEC meeting will be that Monday. And then EMS Challenge will present Wednesday, live and online. And there'll be a surgical airway lab that afternoon. So if you're in that area, come on out. It should be a good conference this year. I think last year we had about 300 people in play. December will be at Springville as well. So a lot of good things coming up. Really appreciate the support of the Fire College getting us out and about. All right. So the first thing I want to talk about is some regional updates, some tips, a little bit of inappropriate humor. You like that one? Well, good. Somebody laughed. Maybe you're laughing at me. I don't know. But sweet. So airway management. Please be advised that EMS providers, you should be the gurus of airway management. Okay. People should not die from loss of airway with us, and this is completely obstructed and things we can't manage. But even then, there are things we can do to take care of people. So if you're uncomfortable with simple maneuvers, use of an oral or nasal trumpet. Nasal trumpets kind of went by the wayside for years, but they're a great way to manage the airways on folks who have trismus or you can't get an OPA in. We're going to train with some of those today, along with some passive oxygenation. Blind insertion devices. The EMT in the state of Alabama can place BIADs, and that's above the national standard. So with a lot of things that we can do. And obviously, I'm a big fan of medics intubating in the era of COVID. One of the best things COVID did for us was American Heart changed some of their guidelines and recommended early intubation and out-of-hospital cardiac arrest. And that's more for patient and staff safety. Put a little filter on there. But again, it goes back to the fact that EMS should be managing these airways. So simple adjuncts. If you're uncomfortable with any of these things, please practice with them. And then passive oxygenation is a big thing we're talking about in the labs today. So for years, we were taught in paramedic school and nursing school and medical school, there's a low flow and high flow O2. High flow is a non-rebreather, low flow is a nasal cannula. Well, my opinion is that's incorrect. Another good thing that COVID taught us is that nasal cannulas can give a good bit of oxygen. So if you have someone with the upper airway obstruction, someone in cardiac arrest, someone that has a difficult airway to manage, you can at least oxygenate them. Nasal cannula on them, crank that up to about 15 liters, and they get some passive O2, which is better than no O2. We know hypoxia kills people, and this fixes the hypoxia problem. Obviously we got to ventilate them if we can, right? But if nothing else, oxygen is not bad for our patients in the short term. I know there's somebody right now in the chat feature saying, but American Heart says oxygen is bad. There are good studies that O2 is bad, long-term use, 24 hours in people who are critically ill, strokes, heart attacks, the free radicals. I get all that stuff. But there's more data to show that people die in the field from hypoxia. So I'd rather us overtreat initially than undertreat. Oh, somebody's trying to get in. Wait. So iGels, blind insertion devices, the iGels in the area. Some folks are using the AirTrack. There's also the King. I don't sell any of these. I don't care what you use. Just know how to use it. If you've never used one before, the first time you use it should not be at 2 o'clock in the morning on a real patient, right? You got to train. The other thing, if you're practicing is ALS1, as a paramedic or above, right? And you're using an iGel or a King, you got to use capnography. If capnography is not working, the blind insertion device is not working. I can't make a BLS crew, an EMT or advanced EMT that doesn't have cardiac monitoring or end-tidal CO2 waveform abilities use these. But if you're a medic, you have this. State says you do. So if you're using an iGel, a King, you got to use capnography. The other thing, in today's era, there's no reason to have missed esophageal intubations. Okay, if you practice medicine or paramedicine long enough, you will intubate the esophagus. No harm, no foul. There are bad airways out there, but that tube does not stay in there. You recognize it immediately, you pull it, and you go back to basic airway adjuncts. Passive O2, nasal trumpets, BVM, whatever you got. No exception for this region. If you intubate somebody, you got to have waveform capnography. It should be documented in the narrative that you see the waveform and a number. And I'm just telling you, it's going to keep you out of trouble. Is anybody using the litmus paper, the easy caps? Y'all have those out here at Mountain Brook? Yeah, so these are fine too. So if you want to use this for initial confirmation and then slide the waveform on a few seconds later, that's very reasonable. We do this in the hospital. I got no problem with that. But at some point, fairly soon, if you're not using if you're using this fairly soon, put the end-tidal on. If you're not using this, the first bag post-intubation should have your waveform capnography, and you should see a waveform and a number. All right. So friendly reminders, and I say this a lot of times with the EMS challenge, 12 leads. If you're gonna get a 12 lead on somebody, do it early, on scene. Time to 12 leads should be quickly if you think they need a 12 lead, okay? If the 12 lead is normal and the patient makes you uncomfortable and you're concerned about them, is this ACS, is there something else going on, are they having dysrhythmias, repeat that 12 lead. There's no extra charge to the patient. There's no risk to the patient. You can't harm them. The only risk for doing more than 112 lead is you got to look at it and say STEMI or no STEMI and do something with it. Okay. Capnography. I can't stress it enough. Always use capnography. Medics, you got to use it for blind insertion devices, but any ET tube has capnography. If you cannot get waveform capnography, my advice, pull that tube, manage the airway some other way. You cannot defend a missed esophageal intubation. We have too many ways to do it. There's some other ways you can confirm ET2 placement. What are some other ways to confirm besides capnography? Stethoscope, you can listen to your patient. No belly sounds, the chest is moving. That's one. I'm happy with that. What else can you do? Mist in the tube. I see that all the time documented. What else can you do? Yeah, the patient should get better, right? Yeah, clinical improvement. Yeah, what's another thing you can do? You can watch it go in, right? You can watch it go in. Who's got video scopes? You got video scopes in Mountain Brook? Take a picture, and there's no doubt, right? You got a video or a still picture. You can take your ET tube, excuse me, your bougie. If you used it to put the tube in, it makes it easier. If you didn't use the bougie and you're concerned about it, take the bougie, put it down the ET tube. If it goes all the way in, you're in the wrong hole. You're in the esophagus. If it goes in and stops, you're probably in the right hole. There's right hole, wrong hole, right? All those things are fantastic. I see all that documented in charts. Those are great to put on there. But at the very end, you still got to say, I see waveform and a number. Waveform capnography positive at 30, at 40, whatever you got. If you don't, that cannot be defended in a court or a QI. Okay. Epidosing. Epi's getting hard to be found some days. It's very important we get first dose epi on board on cardiac arrest, adult and kids, as quick as you can. If you get IV access, use that. If not, drill them. Second dose epi, we're kind of spacing out now. There's pretty good data that First dose epi is good. Second dose may be okay. Third or fourth dose epi is probably not good for brains. So first dose epi in immediately, as soon as you can in cardiac arrest. Second dose, the places that I'm working with, we're going to start spacing that out and doing it every 5 minutes instead of every 3 minutes. Okay. There's some areas that are doing first dose epi and hanging an epi infusion and just running it wide open at that point. That's up to you and your medical director. There's some places that are just doing epi as an infusion from the get-go. I still think the data is pretty strong. 1 mg epi in cardiac arrest, quick as you can, and then second dose at 5 minutes or start an infusion. But places that I work with, we're going to do the every 5 minutes. Narcan. If you look at the numbers for the state, in the BRIMS region, we're using about half or more than half of the Narcan in the state. Either we have more opioid overdoses or we just like Narcan. One of the two. I'm not sure which it is, okay? So a little bit of inappropriate humor, right? Everybody gets Narcan now for ultra-mental status. I got no problem with that. There's some drugs out there that can make you not breathe that Narcan doesn't work on, right? There's benzos, there's weird things. The fentanyl that's out there, some of the doses of Narcan are pretty high. My advice, if you're going to be using Narcan, you give 1 dose as you manage the airway as an engine company or a BLS crew, if you're EMTs, manage the airway, 1 dose of nasal Narcan. If that works, great. High five your buddy, take care of the patient. If that doesn't work, don't worry about it. Manage the airway. When ALS gets there, if you're a medic and you want to give a dose IV, that's fine. But I think the days of giving people 6, 8, 10, 12 of Narcan should be over. Narcan's fairly expensive. It's hard to come by. We got to be appropriate use of it. All right. The other thing is the people that overdose and we give Narcan in the field, how many of those do y'all see that PRT? They wake up and they're like, peace out, Cub Scout. I'm not going to the hospital. Right? Yeah. The rate that they die is higher than the rate of people that have chest pain that come to the ER that we send home. The point behind that is opioid abuse, opioid use disorder, whatever you want to call it, is bad and people are dying. So our goal is to manage the airway, all right? And if we can get them to the hospital, maybe we have resources that can get them into some treatment, all right? The other thing is, who gives Narcan in cardiac arrest? Nobody's going to raise their hand because I asked that question. We used to. Good answer, yeah. So nasal Narcan in cardiac arrest never works because if you have no pulse, you have no blood supply to the nose hole. Nasal Narcan does not work in cardiac arrest. So places that I work with, when I'm reviewing stuff, if you give Narcan in cardiac arrest, if you give it for a known opioid overdose and you give it after you manage the airway with simple maneuvers and after you give epi, I won't fuss at you much. But if you're giving a bunch of Narcan, you're giving it early in the code, that's wrong. Remember, opioids make you not breathe and make your blood pressure get low. In a cardiac arrest, if you manage the airway, you fix the not breathing part. If you give epi, you manage the blood pressure part. I hear beeps. Y'all hear beeps or is it just... Okay, good. Made me nervous. Sweet. All right. Solumedrol is out there. Remember, solumedrol is a great drug for allergic reactions. It's also good for asthma, shortness of breath. The risk for this would be folks that are pregnant or folks that are diabetic, because the solumedrol make your glucose go up. The steroid is concerning for use in pregnancy as well. But my advice would be if I have someone who's having anaphylaxis that I'm giving epi to, they're going to be getting solumedrol because the risk of dying from anaphylaxis is higher than the risk of making them have hyperglycemia if they're diabetic. All right. Or if they're having an asthma attack and I'm looking and think to myself that these guys are critically ill, I'm giving multiple nebs, IM, epi, mag, they get solumedrol. And Toradol, pretty good drug for pain control. It's not an opioid. The advanced EMT can use that now. But remember, cut the dose down. The state says 60 IM, 30 IV. Probably need to cut that in half and doing 30 IM, 15 IV. If they're pregnant, no Toradol. If they have any hint of a kidney problem, no Toradol, or you can actually hurt them. So those are my friendly reminders, and this is the not so friendly reminder. This is a law firm that specializes on victims who've had medical malpractice as far as airway management issues. Okay, American healthcare. So be very wise in the way you manage airways. Capnography, I cannot stress that enough. All right, let's get on to 12 leads. We hit 12 leads pretty hard. That was the first thing we kind of started with the EMS challenge, and I'm still pushing this hard. In our region, we have the STEMI system. The state says that you have to have STEMI on the EKG when you print it off to put them in the system. We know the machines are not that accurate. About 25% of the people that go to the cath lab Well, that's not a good number to put. The point behind that is there are a lot of patients that have STEMIs on their EKGs. The machine does not read, and it's up to you as the medic to interpret these things, okay? And it doesn't have to be complicated. It's just a pragmatic, reasonable approach. I look at EKGs. Are they too fast, too slow, or okay? Too fast, the rate's 50 to 150. I like American Heart. Is it wide or narrow? Is it regular or irregular? Too slow, there are three things I think about that cause bradycardias. There's drugs, electrolytes, or ischemia. Anything else you pick up on your primary exam. So the 6-month-old that is blue and not breathing with a heart rate of 50, what's their problem? It's airway, right? The dude shot in the belly, heart rate's 140, 120, 90, 70, what's his problem? He's bleeding out, yeah. So you can pick those things up on your exam. Things you can't pick up is certain drugs, calcium channel blockers, beta blockers, electrolytes, or should be light, which is hyperkalemia, and then ischemia, STEMIs and NSTEMIs. If the rate's between 50 and 150, those are the ones that are kind of either something scary or something not scary. And that's what you as the medic should be able to interpret. You should be able to say this is a STEMI or not a STEMI. All right. If you don't pick up some of the infectious stuff, some of the weird drugs, TCAs, I got no problem with that. But you should be able to look at an EKG and say if they're a STEMI or no STEMI, so you can take care of that person in front of you. Know how to calculate a rate, not just look at the monitor. I use the box method. So if I got something printed out, I can look at it. I say 300, 150, 100, 75. If I get to that number, my mind starts wandering and thinking about going fishing or something, and I know they're way too bradycardic. But have a way to calculate the rate. You got to know your intervals, the PR interval. What does a prolonged PR interval tell people? What is that? Remember that from medic school? Anybody? First 3 heart block. What do you do for first 3 heart blocks? Are they concerning? Nah. You say, yeah, you got a first 3 heart block, but I don't care, right? But a prolonged PR in the setting of wide QRS makes me think hyperkalemia. So it's important to know these intervals. If you don't know what a QRS, if it's wide or narrow, you can't figure out is it VTAC or not VTAC. The QT interval is very important. A long QT will make people go into torsades, especially we give certain medicines that we use routinely. So you got to understand that as well. All right, so this one, too fast, too slow, or okay? Okay, yeah, I think that's okay. The machine says 73. You never trust the machine though, right? So I'm going to say there's 300, 150. Oh, look at that. A touch changes the screen. I like that. It's a high-tech smartboard. All right, so 300, 150, 100, 75, 60. So we're in the 70th range. I'm good with that. So the rate's okay. Now I'll look for injury patterns, and I'll look laterally, which is 1, AVL, and 5 and 6. I'm looking for ST elevation. The next place I look is 2, 3, and AVF. These are my inferior leads. Right, and I'm looking for ST elevation or depression. If I have ST elevation in any 2 of these leads, the day is done. It is now a STEMI, it's a critical patient. I start working on interventions, all right, and get them to a cath lab. V1 through V4, these are your septal leads, 1 and 2, and your anterior is 3 and 4. Elevation there is concerning for a big left main or lateral infarct. And then depression in V2, 3, or 4 is concerning for a posterior infarct. Okay. The last place I look is AVR. Lead 1 should be opposite of AVR. So if you're up in 1, you should be down in AVR. We used to say that's all this was good for. In reality, if you're elevated in lead AVR and got depression anywhere else, it's a STEMI equivalent, right? This could be a left main or a right main infarct. So it's a STEMI equivalent. The machine will not pick that up. That's something that you as a medic are going to have to pick up, okay? After I look there, I go to lead 2, and I'm looking for my intervals. So my PR interval is reasonable. I'm looking for a QRS, is it wide or narrow, and the QT. All right. If that looks well, before I do anything else, I go one more time through my injury patterns, lateral, inferior, V1 through V4, and I make sure I'm not missing the STEMI. There's some days I've been up way too long, and I'm really tired, so I use this as kind of a pattern recognition, okay? On this one, when we look at lead 2, we recognize that we have a wide QRS. If you have a wide QRS, the next thing you want to go to is go to V1. And this is looking for left or right bundle branch blocks. There's some chairs up front, gentlemen, if y'all want them. Okay, I know I'm pretty intimidating, so yeah. I don't have COVID. Yeah. Oh, yeah. So V1, right? So Y complex QRS, I go to V1, and I make it simple. If the big deflection is going down, that's a left bundle. And that's important because if this says left bundle branch block, the machine's going to stop interpretation. It's not going to say STEMI or anything else. The machine says it's a left bundle, we can't interpret it. And that's junk. We actually can. It's something called Scarbosa's criteria we can use to look at this. But it gives you some information, okay? So this is a left bundle here. What causes a left bundle branch block? Anybody know? Anybody care? No one cares. Good, good, good. Yeah. What now? LV, okay, I said WH. I was like, what's a WH? Yeah. So LVH. So anything that enlarges this left ventricle, it stretches out this conduction pathway. It makes it longer to get electricity through there. So you get that wide QRS. That's what a bundle branch block is. So heart disease, chronic hypertension, things of that nature, cardiomyopathy, all right, will make a left bundle branch block. So to determine if you got a left bundle, you got to first have a wide QRS. And then the way I talk about it is I go to V1. If it's down, it's left bundle. There's some other indicators, other ways to look at this. If you want to learn those, that's fine. This is the quick, cheap, redneck way to get it done to give you some information that you need, okay? So left bundle branch block. Scarbosa's criteria. So before 2013, American Heart said if someone had chest pain in a left bundle, that you treated them like a heart attack. So you gave them lytics, you did certain things, you managed them. What we found out is a lot of folks have left bundles and aren't having an acute coronary syndrome. So Scarbosa's criteria is a way to look at a left bundle and say, is it STEMI or no STEMI? So if I was looking at this and I went through my injury patterns, leads 1, AVL, 5, and 6, you can see you got some inversions that should make you uncomfortable. I can't see 2, 3, and AVF because of that big heart, right? But V1 through V4, we're elevated in V2, V1, V3. So classically, a left bundle, you'd say this is a STEMI, right? Elevation there, reciprocal changes, makes you uncomfortable. But this is a left bundle, and that's always present. So with Scarbosa, what I'm looking for is if I have one big box of elevation here, that's concerning. Less than one big box is not. So we say discord is good. QRS complex down, T wave up. If it's not more than one big box, probably not a STEMI. That's part of Scarbosa's. Obviously, concordant ST elevation in a left bundle, right bundle, no bundle is a STEMI. The posterior findings we talked about in V1, 2, or 3 are STEMI, left bundle, no bundle. And this is where the left bundle Scarbosa comes in really, and that's discord is good, greater than one big box. Okay. So this left bundle, machine doesn't interpret. 1, AVL, 5, and 6, same thing as the last one, 2, 3, and AVF. V1 through V4 are concerning. AVR is opposite, points down here, points up there, so we're good. I look at my injury pattern, my intervals. PR interval is a little bit long. QRS is wide. I go to V1, it points down, it's the left bundle. So that makes me think that this elevation is okay. Good. Only one person has their eyes uncrossed. I like that. That's good. That's good. That's good. The key to understanding 12 leads is doing a lot. So if you're running calls where you run 20, 12 leads a shift and you're looking at them, you're good. If you're not doing 20 a shift, you're not doing good. You got to look at more because what's going to happen is you're going to miss something one day that's going to hurt somebody and you're going to feel bad about it. So Wave Maven is a great website. Life in the Fast Lane is another good website for you. There are numerous places out there. Find some source to look at 12 leads. All right. What about this one? Too fast, too slow, or okay? No comments. I like that. Yeah. Yeah, so the rate's okay-ish, right? So at first glance, it should make me uncomfortable. It looks abnormal. So now I'm gonna go through my pattern recognition. I'm gonna look at 1, AVL, and 5 and 6. It looks funky, but I don't see any ST elevation, no big STEMI. 2, 3, and AVF, I got some T-wave inversion. That should make me uncomfortable, but it's not a STEMI. V1 through V4, this should make you uncomfortable, right? So by what I talked about a few minutes ago, this is a posterior infarct, right? Should make you very uncomfortable. I'm still gonna go through my mnemonics. I'm gonna go to AVR. It's up there, down in 1, leads are good. I'm gonna look for intervals. PR interval looks reasonable. QRS is wide. So I go over here and the predominant inflection is going up. So this is not a left bundle, this is a right bundle, right? So good news, in a right bundle, this is normal. So now I'm still concerned about the patient. They're still going to get the appropriate care and therapy. But in my mind, I'm thinking, okay, this is a right bundle. This is probably not a posterior infarct. Now, if dude's sitting there pouring sweat, said he's had 3 heart attacks, blood pressure is low, and he looks like dirt, he still gets appropriate care, right? But EKG is more reassuring with the right bundle. Again, every EKG, have a way to look at them. If you don't like my method, that's fine. Find a method that works for you that looks for injury patterns. So what causes a right bundle? Put the answer on the board. I like doing that. My kids really like it when I do that too. Yeah. Anything that jacks up the right side of the heart. Okay, so people with chronic hypertension get left-sided heart failure, eventually get right-sided heart failure. Okay, but the more concerning thing from us, from an EMS and an ER standpoint, is acute things that jack up the right heart. So, dude, swollen leg, passes out, now is dyspneic, tachycardic, hypoxic, and got a right bundle in his EKG. What's going on with that person? It could be fluid retention, yeah. So it could be pulmonary edema, chronic stuff that causes a right bundle. I'll take that as an answer. What else could it be? What if they smoked for 40 years? Yeah, so it could be a PE. That's the big concerning thing. A PE causes massive acute right heart strain. So you see tachycardia and a new right bundle. Sometimes you see AFib or aflutter because it stretches that atria so much. People that smoke, have pulmonary hypertension, they'll have right bundles. So anything that causes increased strain on the right side of the heart, so anything that jacks up the lungs will cause a right bundle. Cool. Right bundle branch block. This is just a schematic that kind of shows you the injury patterns. So lateral is a circumflex, left main, elevation in the AVR that shows depression inferiorly is a right coronary, or over laterally is a left main. Oh, these are for West. The Chief Ward likes these. Yeah. Anybody get the joke from that one? Maybe, maybe not. And I show this every time. So if you've seen EMS Challenge, you're probably sick of it, but still going to show it again. What's wrong with this picture right here? I don't believe that. Yeah, no, you're sick of it. I know you are. Yeah. The blood pressure is ridiculous, right? The point to this is don't trust the machine. As a medic, you should be able to interpret a 12 lead. We learned how to do junctional rhythms, AFib, VTAC, all that stuff in medic school years ago. Those days are gone. We still got to know that. That's actually going down to the advanced EMT programs. Now we got to be able to read 12 leads. So do not trust the machines, right? Do not trust the machines. And that's the other humor from the first humor. Thank you for smiling. Sorry, it was a great movie. Oh man, it's not going to run. All right, I had a video of a ST elevation in a cath lab, which I'm scared to touch that. There we go. And it's still not running. All right. Semi-inappropriate medical humor for the doctors. I'm not a big graph or chart guy. All right, so let's look at this one. Too fast, too slow, or okay? I would say it's too fast, right? So I say 50 to 150, 50 to 140 is too fast. Machine says 50, right? So I'm going to calculate it. I'm going to say 300, 151. That's kind of weird. Wait a minute. Okay. So it's a little bit fast, but it's also what? Irregular, right? So if it's too fast, I'm going to think regular or irregular. This one's pretty easy to pick up regularity. What's another way to determine if they have a regular or irregular rhythm? The easiest way? Touch a pulse, touch them, their neck, their wrist, their groin, all right? Nowhere else. Determine regularity, right? So this is irregular, and is it narrow, wide, complex? Which one? Narrow or wide? Yeah, I'm gonna call it kind of narrow. What's it say? So it's still less than 120. So narrow enough. I like that. Someone spoke up. Praise God. Thank you. Yes, sir. Would you give her a coin, please, for speaking up? That's right. Or $1. Yeah. So narrow, complex, irregular, tachycardia, What is this probably? AFib RVR, yeah. AFib is probably one of the most common dysrhythmias you're going to see. Older folks get it. Folks who smoke get it. If you live long enough, you will eventually get AFib. So you want to get there at some point in life, right? So AFib RVR. Too many birthdays. That's right. Yeah. Can you really have too many? I don't know. All right. So AFib causes two problems: decreased cardiac output. So if you have a good, strong heart to begin with, AFib RVR really doesn't bug you. If you have bad heart failure, low EF, ejection fracture, AFib can really jack with you. And then the biggest risk that we see these days is thrombus formation, big risk for strokes, right? So AFib comes by usually atrial stretching. So people who have COPD, right-sided heart failure, that atria gets big because of pulmonary pressures. It stretches the atrium, and they go into AFib. People with left bundles, chronic hypertension, same thing. All right. Causes of AFib, hypertension we talked about, thyroid. This is something we pick up in the hospital 3 days later. So if I got somebody that's hyperthyroid, I've already probably worked them up for STEMIs, AFib, drug indigestions, meningitis, all kind of things. And then 2 days later, the lab tests come back, and I'm like, oh, well, crap, it was just thyroid. So that's something we won't pick up in the field. Holiday heart, AFib can be caused by alcohol. That's classically the college kid who goes away for college for the first semester, gets drunk as dirt, and now is an AFib. Cocaine, speed, Adderall, ice, meth can cause these things. COPD. PE is the big one for us. So someone who's young, semi-young, and new AFib, RVR, and dyspneic, you got to think PE because you got acute right heart strain. Some of your electrolytes, magnesium, etc., will make you have AFib. Lots of causes. What you got to think about the AFib is the rate, the response to something, or is it the cause of the problem? So if I got AFib at baseline, I go out and walk around this building, I'm going to be in AFib RVR because I'm just tired and out of shape, right? Just like if I have sinus rhythm normally and I walk around here, I'll be in sinus tach. So folks who are having a response, causing that rapid response, don't need medicines to treat it. So the patient who is dehydrated and septic with a heart rate of 150 and AFib does not need diltiazem by our protocols. They need what? Fluids, right? They need fluids, fever control, infection control, those things, right? If I slow their heart rate down, I could actually make them worse. So it's the old thing we learned in medical school: treat the patient, not the monitor, is the rate, the response, or the cause. So maybe treat this in the hospital, AFib. If the onset's less than 48 hours, we can do rate or rhythm control. And most of the docs are doing rate control. So we can do beta blockers. We can do diltiazem just like y'all guys can. If the symptoms are ongoing for more than 48 hours, we usually do nothing but rate control because we don't want to shock them into a sinus rhythm and have them throw a big clot and have a big stroke. So we give them blood thinners for a couple of days, and then we go in and cardiovert them. In reality, what needs to be done is they need a cardiologist to go in and kind of ablate and burn some of those extra pathways and knock the AFib out. And that we usually hold for 3 or 4 years to have to go back and get it done again. This is Chief Ward's other favorite video I show. No. So unstable AFib is probably one of the scariest rhythms you will manage. Somebody who has AFib, RVR, and is already hypotensive. The concern there is you can't give them medicines to slow their heart rate down because that drops the blood pressure. So your really only choice is using electricity. But if you remember, cardiac output is heart rate times stroke volume. So if they have a really bad heart and their heart's beating fast because it has to beat fast to perfuse the body, and you slow their rate down, you can actually make them worse. So if you ever give somebody diltiazem for AFib RVR and their pressure bottoms out, you know you just really hose somebody. So they would get fluids rapidly. What drug would you give to reverse diltiazem? Calcium. Thanks for not saying Narcan. I like that. Right. Calcium, not Narcan. Calcium, right? Same thing. If you had to use synchronized cardioversion because they're unstable and you shock them and their heart rate goes from AFib RVR at 150 to AFib rate of 60, and now they're more altered and more hypotensive, now you got to open your fluids up, and you probably got to start thinking about giving them some drugs to increase their heart rate and blood pressure. Dobutamine is one that we used to carry. Does anybody even carry dobutamine anymore? I don't think so. But dobutamine, milrinone, that patient needs support quickly or they will die on you. So just food for thought. All right, so this is a young male with palpitations. Blood pressure is fine. Respirations are okay. Satin fine. I always get a D-stick. It's the one lab test you can get. Gives you a lot of information. If it reads low, you can fix it. If it reads high, you know what the problem is. Anything else in between doesn't matter in Alabama because everybody has diabetes, right? Sweet. Dude's been drinking the Purple Monster. Those are pretty good. And snorted some Adderall. Too fast, too slow, or okay? Too fast, right. So too fast. Next question, is it wide or narrow complex QRS? Narrow. Is it regular or irregular? Right. So always touch the patient and confirm. So what is this rhythm? SVT. Yeah, the other reassuring thing on this with SVT, you usually see people go up in AVR and they go, oh, hang on. And they go down laterally. That's a strain pattern. That's classic for SVT. The other thing, when I'm looking at rates, I'm not going to worry about injury patterns. A heart rate of 204, yes, every EKG is probably going to look like a STEMI because the heart rate's 204. So I want to fix the rate, repeat the EKG, and look to see if that STEMI is still there. Right? So what am I going to do for this person? What can I do? One more Adderall hit before they go to the hospital so they don't withdraw. Yeah, we can do vagal. Y'all know this, vagal maneuvers. Yeah, so have them bear down, okay? I avoid that sometimes in some patients. I'm afraid they're going to crap on the stretcher, right? But you can bear down like you're having a bowel movement. You can have them blow on their thumb, blow on a syringe. There's some fancy videos on YouTube where you have them blow on a syringe and you throw the legs up in the air and you roll them over. I'm not doing all that. Most patients are way too big and I can't pick them off the ground. But simple vagal maneuvers, bear down, blow on your thumb, tell them an inappropriate joke, stand behind them, clap your hands, shoot your gun, do something to vagal them, right? If that doesn't work, what drug do you give them? Anybody know, anybody care? Atropine, 6 milligrams? No, thank you. Thank you for answering that. Okay. See, you laugh, I laugh, but it's not funny. Okay, it starts with an A. It's close enough. Yeah, adenosine. Yeah, 6 milligrams, right? I usually tell the patients after I push this real fast, hey, you're going to feel like dirt for a second, right? So they should get that sense of impending doom, right? So this is somebody, SVT, pushing a little bit of adenosine. Hello, ma'am, you're going to feel like dirt for a second. My apologies, right? If you don't see a rhythm change, if they don't get sweaty, breathe heavy, look at you like they're going to kill you for a few seconds, adenosine did not get to them. You should see a break. Now, it may go right back into SVT. Sometimes it'll go into A flutter because they were actually in A flutter or A fib and not SVT and you missed it. No harm, no foul for the most part. All right. And then after you do that, repeat a 12 lead. Look for ischemic changes. It's quick and simple. No risk to the patient. All right. If you push the adenosine and nothing happens, it didn't get to them. If you push the adenosine and bubbles go in the IV bag, what does that mean? It went the wrong way. All right. What about this one? Too fast, too slow. Oh, snap. Yes. The first thing you should be doing is you should probably be having hands on that patient, right? So I was working down in Dothan one night and they brought me a 12 lead similar to this from triage. Hey, doc, can you sign this? And I thought it was a joke. And I said, where's the patient, right? So obviously they're alive because we got a 12 lead, right? But what is this rhythm? VTAC. Y complex QRS is VTAC, What if it's AFib RVR with aberrancy? Nope, it's VTAC. We call it VTAC until proven otherwise or people die, right? So how do you treat VTAC? Stable VTAC. Well, stable-ish. They're talking to you. What do you want to know about them? What are they saying? Are they saying roll tide or war eagle? Does that matter? Yeah. Okay, he says war eagle, so we're gonna just walk away, right? Yeah. So American Heart says stability is if they have chest pain, shortness of breath, the diaphoretic, any complaints, they're unstable. And our new protocol says if they're unstable, you shock them, right? I would argue anybody in VTAC is going to have a complaint. If they don't, they're probably not in VTAC with a pulse. They're probably dead. They're not talking to you. So I determine stability is one, they got to have a pulse, right? And two, they need to be awake and alert. If they're altered, I'm going straight to synchronized cardioversion. You come in. You good. If they're altered, I go straight to synchronized cardioversion. If they're talking to me, I'm going to put the leads on, put the pads on, I'm IV access, I'm going to pre-oxygenate them, and I got a couple of choices in drugs. What drugs can I give this? You can give yourself some Versed to calm down, right? That was a joke. Yeah, you snort. That's great. Yeah, be careful with that. The DA, well, never mind. Yeah, so amio. What's the dose of amio that you give? Yeah, so you got a couple choices, all right? You got amio 150 over 10 minutes. If you give it over 6 minutes, it's okay. If you give it over 2 minutes, you're probably okay. If you give it over 30 minutes, you probably just hosed your patient. All right, so 10 minutes is the max. You can also use lidocaine. That's very reasonable, 1.5 mg per kilo. All right, I would not worry about starting an infusion. If the lidocaine works, great. You high-five your partner, you repeat a 12 lead, look for ischemia, you move into the hospital. If the lidocaine does not work, I'd bet you my $3 in my wallet that they're going to start becoming more altered, more unresponsive, and you can go to synchronized cardioversion. Our state says you cannot sedate before you cardiovert, so I would advise if they're still awake after your medication, you call med control. Hey, 48-year-old guy, VTAC, blood pressure is low, gave him lidocaine, did not work. I'm gonna give him some Versed or some ketamine, whatever you want, and synchronized cardiovert. Tell the doc what you want, smile, and say thank you, and then hang up, right? And that's how you get it, all right? So amio or lidocaine, then obviously unstable definition in the state, and mine is they're going to have some kind of complaint and altered mental status. All right, they're self-sedated, they get synchronized cardioversion. Remember, to synchronize cardiovert, you got to have your leads on them and your paddles on them. You can't just have your paddles. If you use just the paddles, that's not cardioversion, that is defibrillation, and you would get to shock them again after that because they would be in VFib at that point. Some ridiculous manner, we're doing a 12 lead on somebody, getting a rhythm strip, and they go into this rhythm. So, VTAC. What other drug could you give? If this looked a little bit different every now and then, but was still Y complex, what other drug would you give them? Magnesium. Remember, torsades is not always unstable, no pulse. You can have runs of torsades. So if I'm giving somebody lidocaine or amio for VTAC, in my mind, I'm always thinking, if this rhythm changes a little bit, potentially torsades, potentially from a long QT issue, they get magnesium. Two causes of VFib or VTAC is a STEMI or congestive heart failure. So I always think about getting these folks to the hospital expeditiously. I always try to capture that VTAC on the monitor. If you can show that to a cardiologist and the guy has chest pain, they have to agree to go to the cath lab. If you don't show them that run of VTAC, they can wait for labs and do other things. And if it is a STEMI or some kind of ACS, the sooner we intervene, the better. So that's very important. All right, this one, too fast, too slow, or okay? Too slow, yeah, right. So you can do the box method. I'm gonna do, let's go, where can I go? It's too slow to even count the boxes, really, isn't it? Yeah, so it's like, well, too slow, all right? So what are we gonna do for this dude? If it's a dude, maybe it's a, never mind. For this patient, what are we gonna do? Recognize they're unstable, my hand's on the pulse, trying to get a quick idea of perfusion. Somebody's throwing them on the blood pressure cuff. We're doing some pre-oxygenation before they go into cardiac arrest. We're getting IV access. Somebody's getting an AccuCheck. Somebody's putting the pads on them. I'm opening fluids up. As I get an appropriate history, and the first drug I'm gonna grab for this dude will be what? We got choices. What'd you say? Yeah, you can do some atropine. 1 milligram of atropine is fantastic. Great drug. A lot of folks don't like it. So 3 things to think about, I mentioned. But atropine, low risk, high yield. It may not work, but it's not going to hurt them. So 1 mg, right? Well, you say 0.5 if they're alive, 1 if they're dead. Forget that. Just give 1 milligram. If it works, high five your partner. If it doesn't work, you're done with it. Okay. 1 mg of atropine, very easy to use, right? So atropine does not work. Guy's got a pressure of 90, still bradycardic in the 40s. What else can we think about and do for this guy? So dopamine's great. Do y'all carry dopamine here at Mountain Brook? All right, y'all currently phasing out. And what are y'all going to? Just epi, push dose epi? Yeah. Oh, perfect. Yeah, yeah. So push dose epi is good as well. Remember, if you're making your own push dose epi, you got to train with it. The first time you mix it and push it should not be at 2 in the morning, and you've never done it before. You give this person with this rhythm 1 to 10,000 epi. He goes from bradycardic and unstable to VTAC and unstable. And I get it. We can recognize that rhythm. It's easy to manage, but it's bad for the patient. So train with that push dose epi. With y'all's levo, y'all going to have pumps or Dollar-Flow, or y'all going to do it old school? Dollar-Flow? Yeah. So the dopamine, if you're hanging that, I spike the bag, I prime it, hook it up to the patient, and I run it wide open. As I'm running it wide open for about a minute and a half, rechecking vital signs, I'm getting a better history, I'm making sure the pads are on the patient. If the patient improves, I break out my cheat sheet, I crank it down to 10 mics per kilo per minute. I call it a day. If they don't improve, I crank it down to 10 mics per kilo per minute, and I start thinking about other things. So push dose epi infusion. If you're using norepi, that's fine as well. A lot of options there. So what else can cause somebody to be bradycardic? So hypoxia. So you make sure the oxygen levels are good. And then the other thing I mentioned earlier was electrolytes. So technically hyperkalemia presents as slow and wide, and you treat that with what drug? Anybody know? Anybody care? Calcium? Yeah. So calcium also increases intracellular calcium when you give them calcium, right? And that's how dopamine, epi, all those drugs work. So a little bolus of calcium is not going to hurt this patient. And if they're at risk for hyperkalemic and they're a slow rhythm, give them calcium. What makes you a risk for hyperkalemia in Alabama? Dialysis, I'll take that. What else? Maybe just living in Alabama, right? So diabetes, hypertension, those are big causes of it, right? What about people on medications that can jack up the kidneys? Anybody on a blood pressure pill like the Syncope or HCTZ, that can cause kidney problems. So my argument is anybody in the Deep South probably is at risk for hyperkalemia. So I use a lot of calcium in all my codes and my peri-arrest patients. Cool. So we talked about atropine. We talked about, there's the calcium and semi-inappropriate fireman humor. All right. More fire, less fire. Okay. Dopamine, we talked about titrating this stuff. And then push dose epi. Make sure you know how to mix it. Different ways to do it. If you're a busy agency, you can just take 1 mg, put in 100 cc bag of saline, label it, and hang it in the back of the truck, and you got it for the day. If you're not busy, you can make your own. But like I said, a good way to do it is go ahead and pre-mix it in a bag. That way you got it for push, or you can spike it and hang it for infusion. And then obviously pacing. So pacing is category A now in our state. So if you look at this patient and you say, this is a complete 3rd-degree heart block, I have no doubts, I'm great with that, and you want to pace them right off the bat, no harm, no foul, go for it. But you better be right. If you pace hyperkalemia, they don't get better, right? So think about things. The other thing is, remember, it uses a lot of energy. So if you got a long haul from the apartment or the park to your truck, you can't plug your thing in, you don't have extra batteries. If you start pacing, there's no stopping. Can't run out. The other thing is, people don't appreciate pacing unless they're altered. So if they're awake and alert and you start pacing them, they're going to cuss you at 60 beats a minute. So you're going to have to get orders to sedate them. Now you got somebody that you're pacing and sedating. So A, B, and C is all jacked up. So my advice is pace them if they're altered and symptomatic and unresponsive to medications. How many, Dr. Willett, how many folks have you paced in the past couple of years? Yeah, less than 5. How about you? Yeah, we say not a lot of people do you have to pace. The norepi works fair to keep the blood pressure up. An epi infusion fixes most of this. Dopamine actually fixes a lot too. So just be advised. If I pace somebody, they're getting a tube from me. Oh, yes, sir. Yep. Yes. Correct. Same way, same thing. Yep. If the pacer's not working, it's like they don't have a pacer. Yep. Those wires do come out, not a problem. So if they say, yeah, I feel weak and dizzy, I look like dirt, you check heart rate's 30, but they got a pacer here. If it's not kicking in, it's not working. Those things are preset. All right. Don't put your pads over the pacing device. All right. If you do, well, don't put your pads over the pacing device. And do what you got to do. Right. It's all based upon what the patient looks like. So supportive care for bradycardia is the ABCs: aggressive, head a bed up, pre-oxygenate. I think about my drugs in order: atropine, calcium, I hang my dopamine, push dose epi, epi infusion, norepi, Okay, whatever you want to do that's appropriate, as long as you train and you're ready for it, and then pace. And if I'm pacing somebody, most of the time, I'm gonna go ahead and get them intubated pretty quick. People ask about blocks. What about blocks? What if it's a 2nd degree type 2 or a 3rd degree? Who cares? The treatment's the same, right? I've seen cardiologists stand at the bedside of a patient with a heart rate of 30, arguing over this a high-grade block or is it just junctional bradycardia? And I'm like, dude's heart rate's 30 and his pressure's 70, right? So manage the patient, all right? If they get to pacing, guess what? They get a pacemaker, internal. If they don't get to pacing, guess what? They may not get one. Manage the patient in front of you. All right, inappropriate humor. Won't leave that slide up long. I will get in trouble. Let's see, what is this one? Too fast, too slow, or okay? So I got 300, 150, 100. I say the rate's okay-ish. So I'm gonna look injury patterns, 1, AVL, 5 and 6, reassuring, 2, 3, and AVF, reassuring, V1 through V4, yeah. A little bit of depression here, but not super concerning. I go back here, I'm looking at my PR interval, my QRS, my QT. So not super concerning. See what this one was. So it's okay-ish. What are we missing here? Ah, I see what I'm missing. What am I missing here? Somebody said it already. Yeah, sweet, QTC, yeah. So I'm tired and I'm trying to go quickly, and so I'll run through this. I'm like, yeah, it's nothing. I threw it down. In reality, look at my intervals. PR is good, QRS is good. What's my QT? QRS, T wave. Way too long. Way too long. Good catch, sir. Way too long. So this person is very prone to going into torsades. Okay, especially if we give them more medicines. What medicines do we have that we can give, that we give every day in EMS that prolongs the QT? Zofran. What other drugs do we give that prolong the QT that we can give? Benadryl. Yeah, Zofran, Benadryl. Drugs that, they don't hurt anybody. In reality, if you get a long QT, they can jack with you. Patients that are high risk for long QT are psych patients. Most of your psych medications prolong the QT. And the folks who are malnourished or alcoholics, folks with diarrhea, it makes their MAG levels get low, they get a long QT. So next question, long QT, what would you do to treat this? This is a category B call though, but what do you treat torsades with? Magnesium, right? So magnesium, cool. So this leads to torsades. This is a sick patient. This long QT needs to go to the hospital, even if the only complaint was, I feel bad. Because they can go from feeling bad to torsades, and then we feel bad. Lots of drugs prolong it, Tagamet, erythromycin, all kind of drugs. Haldol. Anybody using Haldol anymore? Or everybody just going to ketamine? Yeah, ketamine's the way to go. Lots of drugs. And the drug of choice is magnesium. So I've shown this several times. This was a patient that was a psych patient in the ER one day. He said he wanted a place to stay and a turkey sandwich. I gave him a turkey sandwich. I'm back running a code, and they say, hey, the dude in room 14's in coding. I'm like, dude in 14 just got a turkey sandwich, right? Well, he actually got nauseous from that turkey sandwich I gave him, and they gave him some Zofran. And you can see where he went from long QT on the monitor into torsades. He got a couple of grams of magnesium, a shock, an ET tube, and a 3-day stay at the Holiday UAB, right? Cool. All right, let's take a break and we'll come back. Sound good? All right, back at Mountain Brook Fire Department. We'll get started again, guys. We're running a few minutes behind. That was me talking too much at the break, but we'll get this moving. So again, if you're in the Mountain Brook area, come out. We're going to do lunch here about noonish. No, sorry, 11ish. And then start the skill lab around noon. We're going to do advanced airway, surgical airways, run through some mega codes. We got an ultrasound we can show you. That's coming to the pre-hospital arena. The places that I work at the paramedic program, initial education, we're training on ultrasounds as well. It's a great way to find out information about a patient. So this 12 lead, too fast, too slow, or okay? I'd say okay. Yeah, nobody even cares anymore, do you? Move on from EKGs, I guess. So Rates okay. I'm gonna look at injury patterns. I'm gonna look 1 AVL and 5 and 6. This makes me uncomfortable. 2, 3 and AVF. This inferior morphology makes me uncomfortable. That makes me get sweaty. V1 through V4. Yeah, I got one lead that makes me uncomfortable. Those are okay. AVR and 1 are opposite, so we're good there. I'm gonna go look at my intervals. My PR interval looks okay. QRS is wide, so I go to V1 and it points down. That tells me what? It's a left bundle, right? Just like the machine, but we don't trust the machines. And the machine also stops interpreting when it says left bundle branch block. So now I can apply Scarbosa, all right? One big box, discord, V1 through V4, nope. Only got one lead of depression here, so that's not a STEMI. But inferiorly, I got discord, that's okay. But what about this right here? That's concordance and ST elevation. So that's a STEMI on a left bundle, a right bundle, or no bundle. So now I got this guy sitting here, diaphoretic chest pain, having a STEMI. EKG doesn't say it. You don't put him in the system. You get to an ER. Who has a wall time of less than 2 minutes at the ERs you go to? Raise your hand. I'll rest my case. This guy's on the wall for 20 minutes waiting to get vitals or an exam. I don't agree with it, but it happens. I'm working what I can on that as well. All right. And he goes from STEMI, left bundle, to all of a sudden he starts having a seizure, right? He's not really seizing though, is he, right? Now he's in VTAC or VFib, he's in cardiac arrest. So we cannot miss these things. So please, if you don't understand the EKGs, you have complications with it as far as reading those as a medic, reach out for assistance, go to the websites. This is where you can make a difference in somebody's lives right there. We can fix this, and this person could potentially go back to a normal, healthy life doing the job they did before they called 911, versus if we miss it, the odds are they cannot. So Scarbosa, get it? Scarbosa? This is a tough crowd. All right, so this one, too fast, too slow, or okay-ish. I would say, meh. The rate's okay, but the rhythm is not okay-ish. It's like, what is this? Are you alive? Hello, knock, knock, right? Reach down, check a pulse. I do see pacer spikes. Conventional therapy teaching is that if you see a paced rhythm, you can't interpret it. You could actually use Scarbosa, all right? The other thing I would think about, I got a paced rhythm in this patient who has a dialysis graft, who missed dialysis the past 2 times because they were too busy, and now they're weak and dizzy. What is this rhythm? Paced rhythm, missed dialysis, Y complex QRS. There's only one answer. Dying rhythm. Okay, I'll say pre-dying. I like that. Yeah. What's the one electrolyte we get concerned about with dialysis patients? Hyperkalemia. This is hyperkalemia, guys. Textbooks talk about peak T waves. Who cares about peak T waves? What you get concerned about is a Y complex QRS and a wide PR interval. I'm not going to get a PR. They're paced. But now I got this wide freaking rhythm. There's no way I'm not going to treat that for hyperkalemia. Don't have IV access. What drug do I give them? As I'm looking to get my drill out. What drug do I give this patient? You don't have IV access to treat hyperkalemia. Don't answer it. Oh, there you go. Albuterol. Yeah, about 20 milligrams. 20 mgs of albuterol, right? That's going to help push that potassium back into the cell until you get your IV access. And then you can give your medications such as calcium. Very good. Sweet. All right. This patient persistently keeps feeling like they're going to pass out and they get dizzy. I would say I can see why. This one is too slow. This one is too fast. So what do you do to treat this patient? Blood pressure is 90. This is their rhythm strip. Pulse rate's anywhere from 40 to 150. They're breathing 20 times a minute, satin fine. Do they get diltiazem? Do they get lidocaine? Do they get amiodarone? Do they get adenosine? Do they get atropine? Do they get dopamine? What do they get from you guys? They get IV, they get fluids, they get a hug, right? You kind of pet the head a little bit, and they go to the hospital. This is complicated. If I give them something to slow this down, that makes this worse. I give something to speed this up, this gets worse. So in reality, you're kind of hosed, I'm kind of hosed. We monitor them, give them some fluids, supportive care, and we get them taken care of at the hospital. Semi-inappropriate humor. So female diaphoretic and vomiting. What are your concerns? What do you do? Get a 12 lead, right? I'm talking about 12 leads. That should be easy, right? Get a 12 lead. Ooh, someone said, ooh. Too fast, too slow, or okay? This was a complicated one. Yeah, I say it's kind of too fast. Rates over 140, right? Usually I start thinking I start thinking, how am I going to control this? So is it wide complex or narrow complex? It's wide complex. So technically, if you call this VTAC, I would be content. If you gave them amio or lidocaine, I'm not going to foul you with that. The rate's a little bit slow for VTAC, 148. That's why the machine says a flutter with aberrancy. It could be. The other thing that it could be with that female who's diaphoretic and nauseous, who's been going on for about a day or so, is I can go back and I can start thinking a little bit deeper, a little bit more complicated. And I'm looking at 1, AVL, 5 and 6, 2, 3 and AVF. Those are inverted. V1 through V4 don't really see a T wave. So maybe that's elevation, right? So maybe this is ACS. All right. This one is complicated. This one will kind of trick you. This is one that if I saw it on a patient in the ER, I'm thinking, what's going on? Is it really a flutter? Is the rate the problem, making her feel like dirt? Or is this really some kind of acute ischemia? This is one that's not a slam dunk. This is one that I would call the cardiologist. As I'm managing this patient, I'll probably do some amio to slow her down. If it's AFib or A-flutter, amio works. If it's VTAC, amio works. But leads on, pads on, IV access, I'm getting an AccuCheck, I'm starting some fluids. I'm probably giving her some Zofran. I'm gonna sit her upright. I'm gonna do pre-oxygenation. I'm gonna start some amio at 150, and I'm gonna pick her up and start moving to the hospital. I'm probably gonna send this EKG to the hospital with a cath lab and say, hey, this makes me uncomfortable. Can I put them in the STEMI system? If the doc says yes, great, go to that hospital. If the doc says no, great, go to that hospital, right? Don't drop them off at the hotel. So if this was ACS, we manage that. There's some mnemonics out there. There's the MONA, the FONA. Remember, priority in medication administration will be what for somebody having a STEMI? What drug do they need first? Aspirin. What if they say they have a GI bleed? I've been crapping blood. I got indigestion. I've had gastric ulcers. Do they get aspirin from you still? Yes. As a medic, I'll say yes. If you think the patient's having a STEMI, I don't care if they're crapping blood. They still get an aspirin from you guys. What if they say I took an aspirin an hour ago? What do? Yeah, can you show it to me? If not, you get another one because people call Norco's aspirin or Adderall or the fentanyl, right? So they get an aspirin. At the advanced EMT and the EMT level, if they say they have a history of gastric problems, you don't give them the aspirin. The medics have the ability to look at that 12 lead and say, this makes me uncomfortable that you're having acute coronary syndrome, so I'm going to take that risk and give you the aspirin. So aspirin, that's the A of FONA. I don't know what MONO is. What would the N be? Nitro, right? Vasodilation. If somebody got a heart rate of 150, I'm not popping them nitro. That's contraindicated. I'm gonna work on the rate first, but this is for somebody just having a regular STEMI with a regular rate. Oxygen, I talk about pre-oxygenation. I mentioned that earlier. I won't berate that anymore. A couple liters of nasal cannula. In case they go into cardiac arrest, they start seizing, you can crank that up. You got passive O2. And they can use morphine or fentanyl. Remember, morphine will drop your pressure. I like, this is my new mnemonic for ACS, just because I love mnemonics, right? So the SIT is suspect. I suspect something bad's going on. I'm gonna get a 12 lead. I'm gonna identify it by understanding how to read a 12 lead and say STEMI or no STEMI. And then I'm gonna treat appropriately with the appropriate medications. And I'm gonna start transport because now I'm time sensitive. And then the other part, which is, I should put the memory or get a tattoo. I think left forearm will be a good place for this. A stands for what? aspirin, IV, nitro. What is RTLP? Ride to lightning pads. These guys get defib pads, right? Things that kill you in a STEMI in the first couple of hours is VTAC, VFib, or complete heart block. So you get ride to lightning pads, and then oxygen, and then maybe morphine. So it's SIT-AIVNRTLPOM. Y'all got that? It's on National Registry. Yeah, I know, exactly. Yeah, it's funny though. So somebody having a STEMI, basically you got a clot in this artery, decreases perfusion downstream. The aspirin makes this clot not get bigger. It doesn't break the clot up, but makes it not get bigger. The nitro makes this vessel get bigger, so you get better perfusion. All right. Remember, there's a STEMI checklist the state says you should be doing in all your STEMI patients, just like for your strokes. I know what you're thinking. State says you ought to do it. I say you at least have to ask the questions and risk stratify these people. If this dude becomes unresponsive, altered, cardiac arrest, and you bring him to me and I can't ask these questions, I can't make an informed decision whether or not I give him a blood thinner, a clot buster to fix him. All right. So if you found out he just had spinal surgery a day before he had his heart attack, I know if he goes into cardiac arrest, I cannot give him a thrombolytic. He's got to go to the cath lab. All right. If he's got a history of a brain aneurysm, I cannot give him a thrombolytic. He's got to go to the cath lab. It changes my management. So these questions, at least ask them, write them on your glove, hand them off to the nursing staff, to the doctor when you get to the hospital. Again, the biggest cause of death in STEMIs in the first couple of hours, VFib, VTAC, complete heart block, dysrhythmias. Put them on the pads. Don't put every chest pain patient on the pad. Your boss will get mad at you. Those cost money. They're having a STEMI, they get pads on. All right. Otherwise, what happens is you're back at the rescue, heading to the hospital. That patient starts seizing. You're tired. You think, oh crap, he's having a heart attack and a seizure. You break out some Versed. You push Versed. By the time you get that and you reassess, they're in VFib because what they're really having is a dysrhythmia. So ride to lightning pads. Ride to lightning pads. Wait. So back to this one. This one's complicated, right? So machine says STEMI. I say, meh, maybe. Maybe it's A-flutter with aberrancy. All right. Maybe it's VTAC. Maybe it's a STEMI. Don't know. Either way, they're getting O2, IV. I'm starting fluids. 12 leads going to the hospital. Have somebody else look at it as I manage the patient. I'm probably mixing up some amio. If it's AFib or A-flutter, I can fix that with that as well. Actually, there's a pretty significant left main for this one. And that's just the angiograms. This is a mature lady. I think she went to high school with, never mind, I'll be quiet. Passed out in church while dancing. So she's syncopized, she done fell out. For the fire service guys, do not think lift assist calls are not medical. They are. I cannot tell you how many times I'm doing a chart review and I say we did a lift assist in the morning, but then we went to that same house at 4 o'clock and they were in cardiac arrest. So my supposition is they were probably having more than just fell off the couch earlier. Syncope is a bad thing. People can die from that. Look for things that we can fix, right? So this chick passed out while dancing. I'll begin the ABCs by asking the pertinent history and physical questions. Heart rate's 94, breathing fine. Blood pressure is soft at 102. That's low for anybody in Alabama, right? Breathing 98%. Glucose is fine. Are you a diabetic? Yes or no? If she says yes, I say, do you take shots or pills? If it's shots, I know she's higher risk for bad outcomes. She's probably a type 1. Are you on blood thinners? Any patient you see, you should ask that question. Big change in patient management. Any new meds? This ever happened before? Did the snake get you? Okay, appropriate questions. This is her 12 lead. She passed out. Going to help her, lift assist. She gets a 12 lead. That is syncope. Too fast, too slow, or okay? Okay. So I'm gonna look at injury patterns. 1, AVL and lateral. This should make you uncomfortable. 2, 3 in AVF. V1 through V4. The morphology is concerning, right? V1's a little bit up. I go back, I look at AVR. I'm up in AVR, ST elevation, all right? But I also say my QRS is down up here, so we're good. I'm gonna look PR, QRS looks good, QT is fine. But I'm up in AVR and I have this depression laterally. So by the 2013 American Heart Association, this is a STEMI equivalent. Big word that means, hey, it can be a STEMI, right? So up in AVR, older person, it can be a proximal occlusion. Sometimes though, in older people that have bad heart disease, atherosclerosis, you'll see them get hypotensive or tachycardic or sick, and they get that strain pattern like we talked about with the SVT earlier. But up in AVR, down here, machine's not going to say anything about a STEMI. Your brain should be thinking, hey, this is a STEMI equivalent, right? But you also want to ask appropriate questions. This lady actually showed up at the hospital. EKG was done. We got cards coming to see her, rushing her back, popping the aspirin in her mouth hole, thinking about doing other anticoagulations for her. Then we start asking questions. She had a history of a stroke. She's on Plavix, which is another aspirin inhibitor, sort of like aspirin, a platelet inhibitor. She's on Coumadin, a blood thinner. And she said she's been doing that. Anybody know what that is? That didn't sound good. Let me change it. How about that? Everybody heard that phrase before? Boo-booing. Said she'd been boo-booing some dark stuff, right? So she'd been crapping blood for about a day, right? So now I got an older lady, hypotensive, tachycardic, syncopized with an abnormal EKG who says she's crapping blood. And we just started some aspirin on her. So I got to decide, do we anticoagulate her because she's having a STEMI, or there's something else going on? And in reality, she was just volume down. She had probably lost half her blood volume over the course of a week due to a GI bleed. And the workload in her heart was exceeding what it could be done. So she was anemic. And that's why she had that elevation in AVR. So at that point, we stopped any more blood thinners. She gets fluids. She got a couple of units of blood, and her repeat EKG was normal. We got that from the history, though. Cool. So medicine gets more confusing. There's more layers to kind of go through. Cool. Questions, comments, statements within reason? 43-year-old with a complaint of passed out. In family states, they found her, I said her, I guess that's a her, him, on the floor, remote history of some migraines. So what are you going to do for this patient? They're laying on the floor, kind of moaning. They get up. Yeah, of course we are. We're not. Yeah. Quick patient assessment. Kneel down. Hey, ma'am, what's going on? Reach down, checking a pulse. Somebody's moving around back, then raise the head up a little bit, check for any kind of trauma. Put her on the 3-lead, get a set of vitals, get an Accu-check. Blood pressure is 190/90, breathing about 16 times a minute. Heart rate's a little tacky, sats are 94. Blood glucose is fine. She's alert. She said she can't open her eyes. The bathroom light hurts. Worst headache of her life. And she woke up on the floor. So you ask her to move everything because she fell. She had a headache. She can move her arms and legs, obeys commands. What's going on with this person? That guy's like falling at a rapid rate, isn't he? That's making me get dizzy. I can't look at that anymore. I don't know how that sped up. What's going on? Yeah. Which one's more concerning? Popping a head bleed. I'm not sure that's the medical phrase either, but yes. Yeah. So syncope and headache should make you think subarachnoid hemorrhage, head bleed, popping a head bleed. That's my next tattoo, popping a head bleed, right? Yeah, these are very bad, right? Even in people with chronic headaches, chronic migraines, you see a lot of that. Sudden, acute, worst headache of your life, and syncope should make you think subarachnoid hemorrhage, all right? Syncope and headache is a head bleed, right? So what's going on here is you got weakness in the vessels somewhere in the brain, and for some reason that thing ruptures. Maybe there was too much caffeine, too much stress. Maybe we don't know why it ruptured, but it did. And you get bleeding in the subarachnoid space, right, which is deep under this layer here. You get blood in the ventricles. The blood circulates around, going down to the brainstem, and you have a lot of problems. These can be very minor to very bad. The problem is when you rupture this aneurysm, you don't just bleed once and stop. Now you have an open vessel. You get a headache, you hurt. The brain has poor perfusion to part where that vessel went, so the body's response is increased blood pressure. So increasing that blood pressure from pain and the need to circulate blood makes more blood leave, which makes the headache worse, which makes increased intracranial pressure, which sends blood down through the CSF canals, right? Which blocks off CSF flow, which causes increased edema. So it's very bad. These ruptured aneurysms can be fatal. Quickly. Subarachnoid hemorrhage. Most of the time there's a weakness in the vessel somewhere in the circle of Willis. This was named after that show in the 70s. What was that show? Different Strokes. So yeah, get it, Stroke, Willis. See how I did that? Yeah, okay. So, okay, good, thank you. Yes, sir. So, these are usually congenital. You really can't screen people for these. We're not going to take everybody and get them a CT angiogram when they turn 21 to look for this. It's pretty predominant in families. So if there's a family history, then you will get screened, but otherwise you just don't know till it gets you. And it's very sad and concerning because a lot of times these affect people who have normal, healthy lifestyles, and all of a sudden, boom, they got this big, devastating neurological injury. There are different types of aneurysms just based upon their shape. All right, but the problem with all of these is at some point they will rupture. All right. So people that come into the hospital with these headaches, a lot of times we'll scan them quickly. If we can scan them within a couple hours, we can use to see that blood. If they don't have a massive bleed, it's just a small sentinel event, sentinel bleed. A lot of times we can do an LP and we'll see blood in the CSF fluid, and then we'll say, okay, now we got to get the CT angio or an MRI and get neurosurgery involved. But these things can be very, very bad. This is a CAT scan of the head. White in the brain is bad. White is blood. So the patient's head's going that way. The feet are pointing toward jaw and they're looking up. And this is around that circle of Willis. It's extra blood. Star of death. Very bad. So CSF is made, it kind of lubricates, nourishes the brain. It circulates all through the brain, into the ventricles, around the brain stem, and then it goes all the way down. If you get blood in here, this blood will get thick and chunky and start clotting off, and then you get decreased flow of that CSF fluid. So in addition to the bleeding and the damage, you get increased intracranial pressure. So those people can rapidly decline, have seizures, altered mental status. What is this area of the brain right here called? Anybody know? Redneck is brainstem. There's also another name for it. Anybody got it? There you go. Oblongata, right? I can't say it either. Get it? All right. I thought it was funny. Okay, never mind. So what does this part of the brain control? Important stuff. Yeah. Respiratory drive, heart rate. So these folks, you'll see them go tachybrady, maybe SVT, maybe dysrhythmias, maybe bradycardic. You'll see funny breathing patterns. They breathe too fast and they go apneic for a while. They're going to dysrhythmias, cardiac arrest from the brain. On the 12 lead, sometimes you see some ST changes that make you think they're having a STEMI, deep T-wave inversions. So the blood around this is very bad, and that's why these people can arrest pretty quickly. The only treatment that we can really do for those guys is recognize the event early on, get them to the appropriate facility where we can get the angiogram to look. If the vessel is already ruptured, sometimes neurosurgeons can go in and clip these, kind of tie them off depending on where it is in the brain. If it's a small leak, they can go in and coil them and make them not bleed anymore. If there's so much pressure in the brain because it's clotted off and can't decrease the CSF, they'll go in at bedside and put a drain in the ventricles and run that tube down. So in the ER, what they do is they will come in and they'll drill, put a tube in the ventricle, and we'll put it to an external bag with the hopes that we decrease pressure in the brain so we avoid killing the brain for increased intracranial pressure, and so that we don't kill off the brain stem. Obviously, this is a devastating injury. Supportive care, oxygen, blood pressure support, head of bed elevated, dysrhythmia management, prevent vasospasm. Sometimes they use calcium channel blockers. That's way too deep for us. Blood pressure control. So once we recognize that this is a hemorrhage in the brain, we give them medicines in the ER to drop their blood pressure as low as we can. All right, we want it less than 160 or 140 because the lower the blood pressure decreases bleeding. But if we already have swelling in the brain, sometimes you need increased blood pressure to perfuse the rest of the brain. So it's a tight line to walk or a fine line to walk. So key thing here is recognize it. Headache, syncope is a subarachnoid hemorrhage until proven otherwise. If you're wrong and it's not a subarachnoid hemorrhage, great. Your patient's fine. Nobody's going to care. Right? If you're right and it is a subarachnoid and you don't move quick, things can happen that are very bad. And in reality, things will happen that are very bad anyway. There's some rules out there that we use in the ER to talk about syncope, who is high risk for syncope or done fell out. One is the Rolls rule. It's people with heart failure. Remember, 2 causes of VTAC, VFib is congested heart failure. So if somebody has heart failure, they're high risk for dysrhythmias. So folks who have heart failure, they syncopize, we usually put them in the hospital on the cardiac monitor, watch them overnight to make sure they weren't having runs of VTAC, because that kills people. And we can put an implantable defibrillator to fix that. Obviously, anybody with bradycardia or SBTs, people who are anemic are high risk, right? Chest pain and syncope makes me think of a couple things: acute aortic dissection, or maybe a PE. EKG showing a Q wave, and that's just a deep downward inflection. That means they probably had some kind of heart disease, and that's probably related back to the fact they probably have heart failure, and obviously hypoxic people. So these are just some kind of things we think about. So I know on the fire side, you'll make a lot of calls for lift assist, done fell out. Please at least get an EKG and AccuCheck, quick set of vitals on these people, and screen them for high risk things so that we don't miss people that we can take care of and give them a few more days, weeks, or months of life. This is a young female playing in the yard with the grandkids. Family said that she passed out, seized a little bit. She had no pulse. They did CPR. And as y'all get there, she's sitting up kind of mad because her chest hurts and she doesn't know what happened to them. Heart rate's in the 80s, respiration 16, blood pressure is normal for Alabama. She's not hypoxic. You can ask the pertinent questions. Are you diabetic? Do you take medicines? Are you on blood thinners? You can get an AccuCheck, any new meds. This ever happened before? You do your exam. And this is one of the only times I think about listening to heart sounds. So I know every medic here carries a stethoscope and listens to heart sounds and lung sounds all the time, and belly sounds. I know you do it, right? Yeah, me too. Okay. Syncope, you should listen for the heart. Syncope on exertion and a heart murmur makes you think of one thing. There's only 3 murmurs that I get concerned about in the ER. Syncope and a murmur, and then somebody having a STEMI and having a murmur, and then somebody with a fever and a rash and a murmur. Other murmurs, yeah, you can have them. I don't really care. I care deeply, but they're not going to change my clinical evaluation of you, right? So syncope and a murmur, what could that be? Anybody but you? I saw your lips already moving. Anybody in the back? Nobody's going to make any comments. Yes, aortic stenosis. Fantastic. Yeah, sweet. Please confirm shutdown. Hit cancel. Oh, I saved it. Yeah, clear. Sorry. Yeah, aortic stenosis. So you have an older person with a murmur and this stenotic valve. So now they're out there doing exercise. The heart's beating fast. They're happy, having a great day, but they can't pump enough blood through this stenotic valve to perfuse their brains. So they pass out. They pass out. They shake because they probably had a little dysrhythmia. And then they usually can wake up, and we call that syncope. All right. The CPR they did in this patient was probably just a bonus, right? If they run around, get a stenotic valve, have a stenotic valve, pass out, shake a little bit, and don't wake up, what do we call that? Dead, right? So high risk for deadness, right? So syncope or exercise, syncope with exercise and a murmur is aortic stenosis. So treatment in the field for you guys is recognize it. Get a 12 lead, do an EKG, get an AccuCheck, rule out the other things that can cause it, and then stress to them the importance and what you're concerned about. Go to the hospital. We can fix this. Otherwise, next time they may become dead. All right. It's the same thing that happens to that kid in high school playing basketball or football that passes out, seizes, and you hear in the news how they had to do an AED on somebody. It was not aortic stenosis. It was hypertrophic obstructive cardiomyopathy. And don't make me spell that. But you pick that up by listening to the heart. A heart murmur in syncope in an adult is aortic stenosis. In a kid is hokum. All right. The other murmurs, if somebody's having a STEMI, they look like dirt, their blood pressure is low, and I listen to them, they got a big murmur, I'm thinking they've probably blown a valve. They need a cardiothoracic surgeon, not just a cardiologist. Kind of changes the importance of care. And then the other murmur I listen for sometimes is endocarditis. So a guy who does IV drugs, has a new rash on his palms, got a fever. If I listen, he's got a murmur, I think he's got endocarditis, and it kind of changes the way we manage them. Those are only the big three murmurs that I care about. For syncope, this is something I stole from the Emergency Nurses Association, one of their little slide sets. But emergent syncope is CRAPS, so cardiac. All right, we figured this out by looking at 12 leads. Is it too fast, too slow, something weird, long QT? A ruptured AAA. Any acute blood loss will make somebody pass out, whether it be from a GI bleed, an ectopic pregnancy, an aneurysm, blood outside the veins can make you pass out. Aortic stenosis, outflow issues, hokum, pulmonary embolism we talked about, and then subarachnoid hemorrhage. I think we've already looked at this one, haven't we? No, this is a different one. This is not that other one. It looks similar. So this one, too fast, too slow, or okay? I'm gonna say it's too fast. The machine says 170. I'm gonna say 300, 150, so 150 plus. So I'm gonna go back. I'm gonna say, is it narrow Y complex? I would argue it's a Y complex. Is it regular or irregular? Touch the patient, and the pulse is regular. So by definition, what is this? The machine says it's uncertain regular rhythm in a right bundle. What do we say it is? There's only one choice. Oh, you're killing me. I'm fixing to have this rhythm. Oh, man, you got life pack or Zols here? Life pack. Okay, I like that better. Okay, I like the anterior posterior placement on me. Y complex. So I would say you can say that's VTAC, right? You could, right? You could also, if you want to get deep, you can say, yeah, well, maybe it's SVT with the aberrancy in a right bundle. Okay, maybe it's a flutter. If it was irregular, maybe it's a fib with aberrancy. But for the purpose of what we need to think about, if you're uncertain, Y complex tachy, call it VTAC. What drug would you give for this? Starts with the A. Amio, very good. Amiodarone. If it's SVT, that'll fix it. If it's AFib, A flutter, that'll fix it. If it's VTAC, that'll help fix it. All right. Some people will say give them adenosine. If you're confident that this is SVT with aberrancy in the right bundle, and you give adenosine, more power to you. It's category A. If you're wrong, and this is WPW, or it's AFib, A flutter with aberrancy and accessory pathway, you may take them from this to VFib. But if you're right, you're okay. That's not funny. What are you laughing at? Yeah. Actually, it is a huge deal, right? That's right, right. So remember, every medication you give, there's a risk and a benefit, all right? So be wise in what you do, all right? Obviously, this, if you're comfortable and see a lot of 12 leads, you can think a lot deeper into this. And I get it. I see that too. But fall back to the basics. If you're tired, if you're uncomfortable, if it's 2 in the morning, you need to recognize this is too fast. It's regular. It's a little bit wide. So I can defend you all day, every day, if you call that VTAC and you treat it like VTAC. This one I've shown a lot as well. This is a male passed out at Walmart. His story was that he had a big swollen infected leg. He went to the doctor, got some antibiotics. He got put back on his blood pressure medicine, his COPD medicine, got some steroids, a shot in the butt. And then the next morning he passed out at Walmart. Okay. So a lot of folks can think, well, he got a new blood pressure medicine. That can make you feel bad. He's sick. Maybe he's septic. but keep it simple. Dude with the swollen leg, passed out, dyspneic, a little bit hypoxic. Oh, this is funny. Y'all just watch that. All right. There'll be a point to this later, especially for Dr. Davidson. This is for him. All right. And that's their EKG. I even labeled where the patient was. See? Part 2, left lower extremity. Swollen. Look at that. It's good. The way I remember. So I say it's a little bit fast. It's not too fast. It's just tachycardic. I'm going to look injury patterns. 1, AVL and lateral. Got some depression. 2, 3 in AVF. Meh. Looks weird. V1 to V4. Got these posterior changes. AVR. I'm up in AVR some, but main deflection is down. It's opposite of V1. I go back and I look at lead 2. PR interval is meh. Okay-ish. QRS, just a tad bit wide. And I go over here to V1. And it's about half and half, right? I would say this is still a right bundle branch block. So I got a right bundle branch block, tachycardia, syncope, shortness of breath, and left lower extremity edema. What's going on with this patient? What do they got? Don't say anything. She's giving you the answers. I now picked it up. So this is the key. This is it's a double tap, right? Dude gets smacked in the head twice, double tap. Dr. Davidson covered this last week as well, right? This is a PE, guys. Syncope and dyspnea as a PE till proven otherwise. You can also say they got a right bundle. That's concerning. They're also tachycardic. We also have this S1, Q3, T3, right? Doesn't matter. Old dude, swollen leg, shorter breath, syncopized. He's got a PE until proven otherwise. Needs to be recognized. Needs to be taken to the hospital emergently. And when you get to the hospital, you need to go find the doc and say, hey, I got an old dude with the right bundle, tachycardic, who's syncopized and is dyspneic. He's got a PE. Go look at his leg. The doctor should get up, say, thank you very much for your assistance. Walk over to the patient, confirm your diagnosis, give you $20, and send you on your way. In reality, all that's not going to happen, but your conscience is clear. You took care of the patient. You recognize the high-risk threat to them. You explain that to the physician. When you get to the hospital, your job is done. Sweet. Double tap. Dude, that's why I don't play soccer. So PE. Blood clot from the leg, breaks free, travels up, goes to the right ventricle, atria, right ventricle, into the pulmonary artery. They pass out because there's no blood supply going to the lungs. They fall over, they smack the ground, the blood clot breaks up a little bit, and they get perfusion again, right? Or they pass out, they smack the ground, and it doesn't break up, and they go into cardiac arrest. Sweet. Just some CAT scans showing a blood clot. The white is the contrast, big clot there. You can see it over here. They need high flow O2, need to recognize it. In the hospital, we give them aspirin, heparin. Sometimes we give them thrombolytics, just like for heart attacks. We can use TPA, like we use for strokes. We could also use TNK. We're using that for strokes as well, but it's just a clot buster, right? It's just a cool EKG with the cath port. So big inferior STEMI. Inferior is right coronary. You can see the contrast, big occlusion. They put a stent in there. ST elevation changes, patient gets better. Oh, that's a bigger picture of it. So for those of you in the Birmingham region, if you have patients that you put in the STEMI system and you need feedback, you want feedback on the cath reports, the outcome, reach out to your medical director. They can reach out to the hospitals. If I'm your medical director, reach out to me. We can get this stuff. Hospitals are very excited about pre-hospital reports now. In the past, there were metrics we had to use. Door to EKG in the hospital was 10 minutes, or we get dinged. Door to give them a clot buster is 30 minutes. Patient arrival to cath up and stent in place is 90 minutes. The American Heart Association, the hospitals are now looking at the first patient contact to balloon up. So the times have changed. So now they can go back and look at the EMS report and say, okay, Mountain Brook Fire got on scene at 10:53. EKG was done at 10:57. They arrived at the hospital at 11:02 to cath lab at 11:40. They're taking those times and going back to what we show them, which is good because it puts the spotlight on us, makes us work better. It also is going to open up the door for data sharing so that in the future, you'll be able to say, oh, this is Mr. Smith, and now I have access to look at his old EKG and records. And I also have access that when I take him to the hospital will let me know what's going on with them so I can learn from that. So this is moving us a whole lot in the right direction. All right, and this is my last inappropriate humor for the day, or for online anyway. I got 3 rules that I practice by. 1, I don't kill people. All right, kind of funny, kind of not funny, but the medicines you guys carry can really make or break somebody. You give atropine to that guy in SVT, that's bad, right? You give the wrong medication, you pick up the wrong symptoms, you miss that STEMI, people die. The way you don't kill people is you train, you're ready. You run through scenarios in your head. When you have downtime at the station, you train, you participate in Con Ed at your agency level, at the region level, and you try to do the right thing, okay? Try and help people. There's some things I can recognize and I can't fix. If somebody has a subarachnoid hemorrhage, I cannot put that shunt in their brain. They will not survive if I do that. But I can recognize the need for that and get the appropriate help. You can't put that shunt in the brain. You can't give a clot buster for a PE, but you can recognize those things, get them to the hospital, and put that fire in the doctor's backside to get up and go see them, okay? And then I go home with a clear conscience, and that's by being trained well and doing what I can to help people, right? Those are my rules. This is the EMT. If you notice, the EMT is different than the physician. What's different here for those in the room? I know those online have seen this a million times. The doctor has bigger arms, okay? The doctor has, just remember that, bigger arms, okay? That was funny. For EMS, calling the paramedic a healthcare provider is like calling this dude a day worker, right? The work environment you work in is dangerous. We as healthcare, whether it be nursing, hospital administrators, or physicians, should help be supporting you and making sure we give you the tool that you need to take care of the patients. I guess that's my last inappropriate humor. All right. I'd like to thank the Fire College for supporting us, putting us on the road. Thank you, Mountain Brook, for having us here today. Any questions or comments in the room or online? Anybody even there online? No.
So we had a couple of questions come in about the website, and so I listed some links if you're listening online to the 2 EKG tutorial websites that Dr. Ferguson recommends, which is Life in the Fast Lane and Wave Maven.
Yeah.
But there's plenty of resources.
There's plenty. So there's lots of resources out there. You don't have to just use those. Find one, get comfortable. I get it. You got to learn vectors and axes for the 12 leads. Yeah, me too. But then have a way to do some pattern recognition and do this when you're tired. Anybody here work 24-hour shifts? You ever get tired on 24-hour shifts? Anybody here work 48-hour shifts? Yes, my point exactly. Have a way to look at 12 leads so you don't miss the things when you're tired. Anything else, Chief?
No, there was some mention about what about people who just pass out because they're drunk or it's too hot, but I think most of those are pretty self-explanatory.
Yes, but on that case, remember Syncope is a high risk event, right? So it should be ALS care, and they should all get a 12 lead, and you should screen them with appropriate histories. Yeah, if they're drunk and they passed out, so be it, right? But get a 12 lead, get an AccuCheck, all they on blood thinners, and they passed out and smacked their head on the concrete, they probably need to go to the hospital. High risk for a head bleed, okay? So don't just blow them off. Remember, Syncope is high risk. And you can feel bad if you miss something that you could have caught and somebody dies.
Very good. Great lecture. Thanks, Dr. Ferguson. And thanks, Mount. And of course, thanks to Alabama Fire College for their support of Alabama EMS Challenge. On a